Hey everybody, I'm about to be joined by Dr. Michael, who is the founder and medical director of Laurel Fertility Care based in California. And we're going to talk about endometriosis tonight. We're going to talk about the different stages, the causes, the treatments, and the symptoms. I think he's here already, so I'm just going to invite him in now. And if you have any questions whilst we're talking, of course, please do feel free to ask at any point. Fantastic article for us, which is in the link in bio if you would like to check it out, and it will be covering lots of the bits that we'll be talking about tonight. Good evening or good afternoon, Dr. Michael.
Wonderful meeting you,
You
virtually
too.
and otherwise.
Absolutely. How are things in California?
It's a little bit cool. I can't imagine it's any different than where you are, but thank you for allowing us to kind of join and participate in your program here.
Absolutely. So I've just given you a brief introduction, and of course, as I was just saying, you are the founder and the medical director of Laurel Fertility Care, based in California, and you are a fantastic boutique clinic, and you have various locations. So please could you introduce Laurel a little bit, and then we'll talk about endometriosis.
Okay. Well, thanks for allowing us to share. Again, I'm Colin Smichael. I'm the medical director at Laurel Fertility. We've been in the Bay Area for the past now almost 15, 16 years. We've managed and take care of patients from around the world. So we've helped families from even the UK and from France to get pregnant. So our reach does extend beyond our local geography. And we manage and take care of patients throughout various forms of fertility treatment, including egg donation, gestational surrogacy, and IVF. We have managed a lot of patients with endometriosis as well, so hopefully I'll be able to answer some of the questions that arise during the conversation today.
Fantastic. And of course, we're halfway through Endometriosis Awareness Month, aren't we? And you've written a fantastic article, which is on Fertility Help Hub website. I've put the link in the bio so people can read that once we've finished or at any point. And I guess really I want to, or the readers may want to understand a little bit more about what endometriosis is, if people don't already know, and what the causes and symptoms might be.
Okay, well, that's actually a good thing to hear and to know. First, the endometriosis involves the tissue that typically lines the endometrial lining going out and then attaching to either the area surfaces outside the uterus within the pelvis or sometimes further. Typically, it may attach to the fallopian tubes or the ovaries, or it may actually attach to the intestines or the bladder or the bowel. So those are all areas where it can attach. Mild forms of endometriosis primarily involve just the surfaces of the ovary, and it may involve the area next to the uterus. But more severe forms can actually take various forms and actually go on to as far as having obstruction of either the bladder or the bowel, causing a lot of major problems. Patients who have endometriosis and then have a cesarean section can actually have the endometriosis implant in the endometrial in the incision where the C-section incision, so therefore it can travel to different forms. No one quite knows what forms or what causes it. There are a number of different reasons to think that it may involve some backward spill of tissue from the uterus into the pelvic cavity, and that's how it seeds. But although there's a lot of postulations in terms of how it forms, not every woman has it, and it's not always severe in different women. So that's the important part of it. The treatments vary depending what your choices are and what your goals are.
Mm-hmm. And is it hard to diagnose? Do people go undiagnosed for a long time, or can people go undiagnosed?
Women can go for a very long time, and especially now that we're looking more at even teenagers who have these symptoms. Teenagers are ones where they would more likely go undiagnosed because, oftentimes just in terms of, girls having their first menstrual cycles, it may be very painful. So therefore, many times it's misunderstood as just menarchal pain. And so therefore, it's not usually evaluated as thoroughly. But women can go through for years and not get diagnosed. There are some patients who don't have any symptoms at all, and those are probably the ones that are the more difficult ones to manage, because they may come in with, bowel obstruction or kidney obstruction, and that's how it's diagnosed, because the disease is pretty severe. Because we know that endometriosis is what we call an infiltrative disease, where that scar tissue can form and embed and grow into those areas. That's one of the reasons why it may cause that problem in terms of having it, come later on and cause intestinal obstruction or or bladder obstruction, bowel obstruction.
Yeah. And does it help if people are diagnosed earlier on in their life?
It is important to diagnose it early, so therefore, for patients who have symptoms, it's far better to get things evaluated rather than simply just wait and simply just ignore the symptoms. You asked earlier just in terms of how do you diagnose the disease, and before, the only way to diagnose it was by surgically evaluating, either by laparoscopy or some other measures. You can have diagnosis by looking with an ultrasound and seeing endometriomas within the ovary, but that'll tell you that there's an endometrioma. It doesn't tell you anything about what's going on the surface of the ovary or the surface of the intestines and the other areas. Magnetic resonant imaging, or MRI, can also be helpful in terms of letting you know some of those features. But the primary reason, the primary way to diagnose it is going to be with some sort of surgical approach.
Mm-hmm. Yeah. And so obviously a lot of people who are joining and who will be watching this are thinking about fertility. So how does endometriosis affect fertility, and what are some of the common treatments that you use to help the diagnosis or the problem?
Well, not all women with endometriosis will have problems with fertility, but many women who do have endometriosis will have fertility challenges. And so therefore, it's somewhat of, not all women will, but many will. And it's hard to say who. The key thing is just that how it may influence and may affect fertility would be if there are endometriomas that grow and basically develop within the ovary itself. That displaces and then sometimes can reduce the number of viable eggs that are there inside the ovary. Mm-hmm. And that's one way that you might actually have someone find out they have endometriosis. It may also cause a problem, depending on how severe it is, where the egg released from the ovary, but those endometrial implants that cause the inflammation on the peritoneal surfaces, so those implants will then, produce what we call cytokines, or things to destroy the egg and the embryo. So therefore, it'll actually inhibit implantation. So women with endometriosis will have a lower chance of conceiving, depending on severity of their disease, and therefore they may end up wanting to have that treated before going on. Women with mild or moderate disease can actually go through surgery, remove a lot of the implants that are there, and many of them may end up getting pregnant within that first year afterwards. But then again, endometriosis is also a disease that comes back. It never just goes away completely, not until you go through menopause. So therefore, those women, if they go beyond that 1 year period, may end up having more challenges again, and having to go through different procedures to get pregnant. Mm-hmm.
And
women who go through endometriosis will have these different things as well. I'm sorry, go ahead.
No, I was going to ask on that note, when you mention fertility treatment for people who have endometriosis, if they need it, as you said, not everyone will experience issues. What are the common treatments? Is it going straight to IVF, or are there other milder forms of treatment you can do first?
Well, I'd say that not everyone, it depends on age. And so younger women with mild endometriosis could consider going through other measures first before. It does depend on if there is involvement of the fallopian tube. So therefore, patients who are considering go through less aggressive treatment need to have their tubes evaluated using a hysterosalpingogram, or doing a surgery to do a laparoscopy to see if the tubes are open. Because if the tubes are involved, then IVF is the only way to kind of bypass that effect. However, those women who have normal tubes can try less aggressive measures like, using, oral medicines or injectable medicines first before going on to IVF. But I would also say I would not go through a long period of treatment with these measures, because that stimulation with these medicines can also trigger endometriosis to recur a lot faster or increase the severity of the disease. So I would say, if you're considering that option, to try it for a measured amount of time, so 2 to 3 cycles, and then moving on to more aggressive measures if that's not successful.
That's really good to know. Thank you. We've had a question from someone who said that they've had silent symptoms and they're not the most commonly known symptoms for endometriosis. She's asking, is that common?
It's actually very common to have silent symptoms. So therefore, a woman may end up going through, and it's evaluated where, she goes in for an ultrasound and she sees the endometrioma on her ovaries. Women have different pain tolerances, so therefore some may end up having severe, pain with menstrual cycles, but not really think about it as something related to endometriosis.
Okay.
Some will have no symptoms at all because the disease is so severe that it kind of basically infiltrates and causes, a lot of the nerve endings to be sequestered. So therefore, they're not going to have pain at all. And so it does vary quite a bit. And the only way to kind of tell is, by evaluating it either by some as a measure or by surgery.
Okay. And so rather than the silent symptoms, what are the main symptoms that you would normally see for an endometriosis diagnosis?
The main symptoms that patients complain about are pain, especially pain with your menstrual cycles. It's sometimes pretty severe. It's primarily irradiated right around the time of menstrual cycle, within the first several days. That pain can be debilitating, but sometimes it can actually be relatively mild and have significant disease. Others may end up having discomfort with either, bowel movements or having go to the bathroom around the time that they're having their periods, because those are the times when those surfaces may be inflamed because of the endometriosis. Others may complain of having pain with intercourse related to the scar tissue that forms, and then there's actually barriers that actually interfere with that part of it. Those are primarily the symptoms patients complain about related to endometriosis.
And would people with endometriosis commonly have heavier periods as well?
Not necessarily, because it's not related to increasing the size or the volume of the uterus. It's primarily related to the symptoms outside the uterus itself. There is another syndrome called adenomyosis, where there's similar type features where endometriosis or the endometrial lining invades into the wall of the uterus, and those women may end up having heavier periods. But women with endometriosis may not have heavier periods.
Okay. We've had some questions come in on here, so I'll just read those out, and some privately, so I'll try and get through those as well.
That's fine.
So what about pain for 3 to 4 days around ovulation?
Pain around ovulation it may be related to endometriosis, but more likely related to ovulation itself. Women with endometriosis may end up having pain if the egg that's being ovulated is close to or near the endometrioma that's around the ovary. So that's primarily where they may end up feeling pain. But many times or if they're going through some sort of treatment where they're taking medicines to increase the number of eggs they're ovulating, that may end up also causing the endometriosis to flare, if you will, and cause pain. But typically, it's more related to menstrual cycle rather than ovulation when you'll feel the majority of the pain.
Yeah, that makes sense. Someone's asked a very good question. Can endometriosis affect an embryo implantation?
It does. It may influence the implantation slightly, not as significantly. So therefore, we know that women with endometriosis, and especially if there's involvement inside the ovary, will have fewer eggs than women of similar ages. So, picking a number, a woman who's 33 may end up having 12 versus 20 eggs, and so therefore they'll have fewer. Getting those eggs, fertilizing them with IVF, the chance of success is similar. Women with endometriosis may end up having a little bit lower chance in terms of implantation if there's actually a lot of inflammation around that causes the uterus to react. And so many times what you may need it to do is to reduce that inflammation by treating those women with Lupron, so you can shrink those implants before undergoing the transfer, and that eliminates that disparity between the two groups.
It's good to know that there is a treatment for that issue.
That's actually a fairly a good question in terms of, how do you manage and how do you treat many of those patients. Women who are not trying to get pregnant will end up using either birth control pills or some measures to try to reduce those implants from forming, or women who are trying to get pregnant, especially going through surgery, may end up going through some treatment with Lupron to shrink any implants after surgery, and then trying to get pregnant soon after. The goal is to try to reduce any kind of inflammation that's there, so therefore it may be more successful to either conceive naturally or by other measures.
This is really useful. Thank you so much. A couple more questions, if you don't mind.
That's fine.
Someone said that their RE is recommending surgery to diagnose endometriosis, as she suspects that's the problem. This person has tried a few IUIs already. Is the surgery still recommended at that point, would you say?
Well, there are a number of studies, especially studies down in the early to mid 80s, that showed that women with mild endometriosis, if they went through laparoscopy and actually had full remission of their disease, can either get pregnant spontaneously or with minimal treatment. So it all depends in terms of how aggressive you'd like to be. Surgery it may be a first line to actually diagnose how severe the endometriosis is. And it may be something that if you're younger, you can consider. Women who are older, surgery may end up reducing the number of eggs that are, or further reduce the number of eggs that are available. So that may not be the primary thing to consider. But so a lot of it depends on the scenario. It depends on your age, ovarian function, ovarian reserve. Those are the things you might look at.
Okay. And another person has had very bad hip pain on one side before their period. They've got or had endometriosis and mild Adenomyosis. Are these likely to be connected?
Adenomyosis as part of the issue, right? So therefore, that person may end up having a lot more related to not just endometriosis, but sometimes endometriosis can actually go through the bloodstream into remote areas. So the hip, the lungs, there have actually been cases where you have endometriosis migrating to the brain. So all those are rare, but those can occur. So although it's not as likely to say that's truly the cause of her hip pain, it possibly could be. So it does need to be something she needs to explore.
Am I right in thinking that 1 in 10 women have it?
It's fairly common. So yes, you're right in terms of that. Many people actually may have it and not really recognize or know. So therefore that they're not looking at trying to get pregnant. Many times you'll actually see it come up more in terms of women who are trying to get pregnant than not, unless the symptoms are pretty severe. So yes, it's a pretty common scenario, this syndrome.
And someone asked a question today actually about endometriosis surgery. How long would you advise someone to wait to try to conceive or have treatment after they've had surgery?
I would say to try to get pregnant as soon as possible after surgery. There's a window of opportunity that's there. So therefore, if you're not planning to get pregnant soon, unless you actually have pretty severe disease that basically becomes debilitating, I might actually say to hold off on the surgery, because that time frame, the clock starts to tick as soon as you have the surgery, because within that first year is when you're most likely to succeed. So if you basically tried 6 months afterwards, you've wasted 6 months of that interval. So that's important to know.
It's really good to know. Thank you. What about when people get pregnant? What happens to endometriosis then?
That actually is the treatment for endometriosis. So not to say that every woman should go out and try to get pregnant to prevent it or reduce their symptoms from endometriosis, but we know that pregnancy itself is one way that people or physicians tried to treat endometriosis in the past. We know that what happens is just that with endometriosis, the body, or with pregnancy, the body produces a lot of estrogen. Estrogen actually will then burn out the endometriomas that are there. So therefore, pregnancy is a great way to manage and to treat endometriosis. Women who get pregnant and then breastfeed afterwards will actually reduce their symptoms for a longer period of time. So then again, another option that's there. Back earlier in treatment, we used to actually consider pseudo-pregnancy. So therefore, putting patients on continuous birth control pills or using medications like danazol or other anti-estrogens or ways to kind of manage and treat endometriosis by creating that false pregnancy symptom.
Wow. So is it a hormonal thing then?
It is a hormonal thing. It is a hormonal thing, and managing hormonal things trigger and worsen the disease. So therefore, that's important to know. And therefore, what you need to do is to do measures to kind of try to counteract that.
It's great, isn't it, to have awareness months like this? Because for people who...
It is definitely important to know, because the more you ignore it, the more you kind of think that it's not something that you have to worry about, then the more you may be actually contributing to making it worse. And then when you go to treat it later on, then it becomes more problematic.
And also for people who don't have it, to understand, I guess, you know, physically the pain and also emotionally the anxieties that people with it have to go through for a very big period of their life.
That is very true. Women will actually not have symptoms. They'll say, well, I have pain with my menstrual cycle, so therefore it can't be that bad. But no one can walk into someone else's shoes. And it's really important to realize that women with mild endometriosis can actually have debilitating pain. Women with obstruction from either bladder or the bowel or some other processes can have severe endometriosis and not know it. So you can't really presume one's pain level is going to actually be related to the endometriosis itself.
Absolutely. And another question, is an endometrial biopsy a way of diagnosing endometriosis?
That's a recent phenomena where there is a test now actually being evaluated for diagnosis of endometriosis. It relates to the fact that endometriosis, because it is associated with some inflammatory processes, doing an endometrial biopsy sometime in a specific time after ovulation will allow us to kind of to evaluate and identify those cytokines we talked about, those abnormal tissue that's there. The test is called ReceptivaDx, and it does have a fairly sensitive measure for detecting endometriosis. It's not as sensitive or as specific as surgery, so that's important to realize and to know. But it is a non-surgical means in terms of helping patients to diagnose endometriosis. It's more often used in terms of patients who are undergoing fertility assessment or treatment, because it allows us to then help to time the transfer of the embryo and implantation.
That's really good to know. Thank you. And you mentioned before that for people trying to conceive, you know, who have maybe had surgery, try and do that within a year, let's say. How quickly can it come back again? And are POLPs connected to having endometriosis?
It depends on the surgery that was done and how extensive that surgery was. The more you can get rid of the tissue, then the more likely that you're going to end up preventing that recurrence for a period of time. But it's always going to be a fine balance, because if the endometriosis involves the ovary, then what you're also doing when you try to reduce those lesions or fulgurate those lesions, you're also maybe reducing eggs. And so if someone has extensive surgery and they end up doing a lot of manipulation to the ovary, that may end up switching one situation, endometriosis, to the other, where there's now diminution of ovarian reserve, because you're removing too much tissues. True, it'll actually take care of the endometriosis, but for most women, that's not their goal. That's not their purpose. And, you know, again, people used to go through and remove the ovaries entirely for management of endometriosis, but that was well after you finished your decision about having your family, and not something that we'd actually say is a choice to do.
Yeah. And then there have been some more holistic well-being, I guess, natural methods to treat or to manage symptoms or endometriosis. And I know that at Laurel, you're very big on the holistic approach, as well as obviously the medical expertise and care. So in terms of supplementation or fertility massage, foods to eat or avoid, do you have any thoughts on those?
Well, there are a number of different, I would say, adjunctive options you can actually consider in terms of helping to manage that. Unfortunately, unlike PCO, there's not an endometriosis diet you can kind of actually do, but there are things that some Chinese herbs or medicines that would end up reducing some of those symptoms. I think under those circumstances, working with a really skilled acupuncturist or herbalist is going to be important to kind of get those measures. I don't think it's something to kind of undertake on your own just by shopping on Google. But, it's something that's important to kind of know that, with skill help, just like coming to see someone like me, it's important to get help in terms of looking through those other options as well.
Absolutely. And do you have those experts at Laurel that you can put your patients in touch with too?
Although that we don't have them on staff, we actually have a number of referrals that we send patients to in terms of counseling. So therefore, they have that expertise in terms of managing those symptoms there, and we work pretty closely and in concert with them in terms of orchestrating what those treatment options are.
Fantastic. Thank you for that. Back to surgery. When is the best time in a cycle to have surgery?
It's not as much related to the cycle as what your overall goal and timing is. If you had to choose a specific time during the cycle, doing it earlier before ovulation is going to be the primary way. That's when this endometriosis is going to be most visible and easiest to kind of basically diagnose and see. Different type of surgical techniques have evolved to allow us to look and diagnose early lesions. With laparoscopy, you can actually use different colors of light to basically identify the endometrial implants because they may not look the same as other areas within the pelvis. So that's important to realize and to know. So the key thing in terms of trying to do surgery is, I'd say, the timing is important, but finding a skilled physician who knows how to use all those modalities is going to be the important part in terms of diagnosing and treating it.
And is it a painful surgery to have?
Any surgery is painful, but I'd say that most times patients will actually manage much better because you're looking at what you were treating before. Yeah. Women with really significant dysmenorrhea and a lot of discomfort throughout their period, pain with intercourse, may find that after surgery, many of those symptoms are actually either significantly reduced or eliminated entirely, at least for some period. So therefore, what they're doing is weighing the short-term side effects in terms of the surgery itself and the pain in terms of the recovery, which typically lasts about a day or two, to a lot of the protracted feelings they have in terms of living with endometriosis.
Great, thank you. People are saying how wonderful you are and how this advice is brilliant, so thank you so much. And in terms of fertility treatment and IVF success, etc., do you see a difference between the success with patients with endometriosis versus people who don't have it?
There is some difference, but it's primarily related to the number of eggs you can actually retrieve. So comparing the same women of similar ages with everything being the same, endometriosis versus not endometriosis, typically women without endometriosis will have more eggs and therefore a higher chance of success, more opportunities for success. So therefore, that's where the biggest difference may lie. If you had women who had a similar number of eggs and the same quality embryos, there's still a slight reduction in terms of implantation, but that implantation may be, if you managed all the other parameters related to that, and you're having equal relations, if you will, that chance of implantation is going to be similar. So therefore, that you're going to eliminate the effect of endometriosis in terms of the implantation. So yes, it can have an impact. The primary impact is going to be with egg number. If you can overcome egg number by improving egg quality or doing genetic testing to identify normal embryos, those are measures, those are ways to, again, improve your chances for success.
Brilliant, thank you. Do you have time for a couple more questions?
Yeah, I do.
I know we've had a few. You mentioned inflammation being a problem for implantation. Can the surgery cause more inflammation?
Surgery may cause inflammation on the outside of the uterus, not on the inside, because typically you're not operating on the inside of the uterus. Therefore, surgery may mean that you're more likely to need and having to undergo IVF, but doesn't mean that you're going to end up having any problems in terms of getting pregnant and keeping the pregnancy inside the uterus. So
Okay.
that's the biggest impact of surgery.
Okay.
So what you're doing in surgery in terms of how it may help getting pregnant is you're reducing those implants, and therefore you're allowing the person to ovulate, fertilize, and get pregnant naturally, or create an environment where you can get more eggs and more embryos with IVF.
Mm-hmm. Fantastic, thank you. Someone is about to start immune therapy as part of IVF, steroids, etc. Is it likely to help reduce inflammation or my immune response to endometriosis?
I'm sorry, what therapy were they starting?
They're about to start immune therapy, IVIG and steroids as part of their IVF cycle, and they just want to know whether that will likely to help reduce the inflammation of the immune response to their endometriosis.
So it depends on the type of immune therapy. And not all immune therapy are going to be the same. So therefore, there are patients who have recurrent miscarriages, and in those specific subset of patients, immune therapy is going to be important to kind of manage those symptoms and undermine or improve that inhibition in terms of implantation. The immune therapy for endometriosis is primarily reducing inflammation. So it's primarily steroids or using like a baby aspirin as a way to kind of do that part of it, not using like IVIG or Enbryo, Imuran, or all those other measures. Those are probably not related to the same things that are related to treatment for endometriosis.
Okay, thank you so much for that. I'm just going to see what's been sent as some private questions here. Does endo in pouch of Douglas cause pain during intercourse? I don't actually understand that one.
So anatomically, the pouch of Douglas is actually the area right behind the uterus where the in the what we call the posterior cul-de-sac, and that's typically where endometriosis actually occurs, and that's where you're going to find the severity of disease. That's also, unfortunately, when you're having intercourse, that's the part that's actually most impacted. So therefore, that's where patients may feel it more likely. So therefore, if you're going through surgery and you're evaluating that area, you want to try to free up any adhesion to scar or any endometriosis you can find in that area, and that's the primary measure, the primary mean for treatment. Anatomically, once it's corrected, it's not really going to interfere in any other way.
Okay. She also asked whether that affects fertility as well.
The only way it affects the fertility is the degree of inflammation that's there. So therefore, anatomically, it's not either a cause or a detriment to fertility other than the scarring that occurs with endometriosis or with pelvic inflammatory disease or any other measures that may impact that.
Okay, we have one last question, and then if I've missed any or any more come in, then please do ask Dr. Smykel directly, or you can come through Fertility Help Hub and we can put you in touch. Shoulder pain around ovulation and menstrual cycle, could that be connected to endometriosis?
It can be. So therefore, it may actually be where, again, as I said, implants can be anywhere. So if someone's having persistent or recurrent shoulder pain with pregnancy, with menstrual cycles, it may be that the endometriosis implants what we call underneath the diaphragm in that area. And the diaphragm, we know, is actually what relates to the shoulder pain. Right. So oftentimes you may end up having that. What may happen is just that the patient underwent surgery for treatment of endometriosis. During that time, some of the implants went to the upper abdomen and might have actually implanted on the diaphragm. And now they have shoulder pain related to the endometriosis because that's where everything implanted. Similar to when someone has a C-section and then end up having endometriosis in the C-section scar.
Mm-hmm. Thank you so much. This has been so useful. I'm sure everyone's learned a lot. And thank you also for writing a fantastic article all around this, everything we've discussed in lots of detail, which is on the Fertility Help Hub website. As I mentioned before, the link is in the bio directly to go there. So please do have a read. It's very, very well written. And thank you for your expertise tonight. And also just to say, I think that, as you mentioned, you help people from all around the world. So even if people can't travel to your various locations in California, I presume you're consulting virtually at the moment as well.
We definitely will. And thank you for inviting us to join. And I'm glad I was able to participate.
Absolutely. Thank you everyone for joining. Nice to have a chat.
All right. Take
Okay.
care now.
Thanks.
All right.
Bye-bye.
Bye-bye.
Bye.